Hi, I'm Dr. Aparna Rajadaksha, and I am a senior medical consultant with Metropolis Health. It's my pleasure to introduce you to Dr. Jay Mehta. Dr. Jay Mehta, welcome to MedConnect. Dr. Jay Mehta is an IVF specialist and fertility preserving surgeon and the director and founder of Shri IVF and Endometriosis Clinic, which is the highest rated fertility clinic in Mumbai. He is the program director of uterine transplant and advanced endometriosis and gynec cancers at Global Hospitals. Dr. Jay Mehta is the founder of Pran Endoscopy as well. Pran Endoscopy is a mobile endoscopy unit that is used to perform several successful endoscopy surgeries at many hospitals in Mumbai. Dr. Jay Mehta has completed his MBBS from KEM Hospital in Mumbai and has completed his post-graduation from Jubilee Mission Hospital, Thrissur. During post-graduation, Dr. Jay Mehta has been a receiver of many accolades and awards. Meanwhile, he developed a keen interest in minimally invasive surgery and infertility, which has him able to add qualifications in his interests by receiving fellowships and certifications from the US, Austria, and Germany. Dr. Jay Mehta received his degree from Bachelor of Endoscopy from the European Society of Gynecological Endoscopy and has a fellowship in robotic surgery from Celebrations Hospital and Nicholson Center in Florida. Welcome, Dr. Jay Mehta. We are happy to have you here. We'd love to have you talk on your specialty, which is genetic testing with IVF and prenatal genetic testing. Thank you.
Thank you so much for those kind words, and thank you so much to Metropolis and the entire team for adjusting this last minute schedule for me. Unfortunately, quite a lot of times I'm occupied with these type of commitments, but I'm very, very happy to be here. And with the permission, I would just like to start to share the screen. Is that okay? Can I start sharing? Can you guys see the screen? Is my screen visible? It's visible, right? Fine. Okay. So, it's great that I'm here to speak on the prenatal testing, okay, which we need to keep in mind. Okay. Now, whenever we are trying to do or trying to think of prenatal testing, the obvious thing which comes to our mind, okay, is prenatal testing. You do a PGTA for the embryos, you rule out abnormalities, and you try to insert inside absolutely normal, chromosomally normal embryo, or what we say a euploid embryo. Okay, this is what we are supposed to do. What is important to understand is that this is a test which is going to happen. PGTA is going to happen when you do something called as a trophectoderm biopsy. All right, so this is your inner cell mass, and these are your outer cells, and then there is of course the zona which is present. So you are going to make a nick over the zona, and your pipette is going to go inside. It is going to take a biopsy of approximately 3 or 4 cells, and then this is going to be sent for testing for PGTA. All right, this is obviously an invasive way of testing it, and obviously we are trying to move also into non-invasive chromosomal studies for these embryos. But at this point in time, I still think invasive testing is going to be much more better, because non-invasive chromosomal studies are going to be dependent on the culture conditions, okay, and the manner in which the droplet size is cultivated for the embryo culture. That is something which is important, because the reason why I'm speaking of this first is because in order to do a PGTA and in order to get an euploid embryo, you obviously require to do a karyotyping of the couple as a standard test. Okay, so karyotyping of the couple, that is male partner and the female partner, is absolutely mandatory before you get into a PGTA. Obviously, the government of India has had a law, and there are clauses at which one can do a PGTA, and these typically include repeated IVF cycle failures or repeated implantation failures, if I may call it that way, multiple past abortions, okay, or any genetical abnormalities which are proven. Okay, when I talk of genetical abnormalities, which are pre-existent, one more thing comes into the picture, and that is after PGTA, you will be doing something called as PGTM, and this PGTM is then going to try and focus on a single gene locus, okay, of a particular disease. So they need to develop a specific probe for that, and it takes a slightly longer amount of time and slightly higher amount of cost, okay. It's involved when we are doing a PGTM for a particular embryo, all right. Simultaneously, it is also important to understand that when you do all these things and when you have done all these things, how should you as a clinician, I will leave the detailing of the test to the people from Metropolis to explain. Just a minute. Patient. Going. Yeah. So when we are trying to do a PGTA as a clinician, okay, the detailing of the test will be explained by the people from Metropolis. I hope Dr. Anuradha is way more better than me, and she's an expert. I've had one interaction with her in the past. Okay, but what do we need to remember? Okay, just remember this. A euploid embryo doesn't mean that, everything is absolutely normal. All right, it means that an embryo is called euploid, mosaic, and aneuploid. Okay, these are the three main categories which we should try and keep in mind. Okay, mosaicism, when it is less than 30%, okay, is considered to be a euploid embryo. A mosaic embryo is between 30 and 70% abnormalities, and more than 70% of mosaicism is considered to be aneuploid. So the aneuploid embryo is going to be non-transferable. Okay, euploid embryo is the transferable embryo. And in the mosaic embryo, now you have a discrepancy. Either it is a low mosaic or it is a high mosaic. From the clinical perspective, from the clinical standpoint of view, these are the best embryos to transfer. Okay. These are the embryos, if you transfer, they are going to give you a good clinical pregnancy rates in the turn of around 50 to 60%. Of course, not higher than that. Okay. Aneuploid embryos are not recommended for transfer. Okay. But remember one thing, quite a lot of times these mosaic embryos are the discrepancy. So God has gifted these embryos with a mechanism of autocorrection, because what you are trying to test, is the mosaicism detected out of these three cells, which are the trophectoderm cells. They may not be representative of the inner cell mass. They may not be representative of the entire genetic condition of the embryo. So quite a lot of times these embryos can undergo autocorrection, and when they undergo autocorrection, even a mosaic embryo can give rise to a good, healthy clinical pregnancy outcome for a particular couple. Okay, this is something which as a clinician we need to keep in mind, and actually this is the bottom line of this entire talk, whatever we are trying to have here. Okay, when you have something like this which is present, please take home this important point, that these type of embryos, euploid embryos, can be transferred. Mosaic embryos, God has gifted something called as autocorrection. Aneuploid embryos, you don't need to transfer. When you go one step above this, that means when you go into PGTM, obviously because it is a single gene testing which is done, you will clearly know if the embryo is having the representation of that gene or if it is absent representation of that gene, and the embryo without that gene, which is defective, is going to be the embryo which is going to be recommended for transfer. Okay, this is very brief about the entire prenatal testing, all right, which I thought I should cover, so that this flow chart gives an idea to every clinician to focus upon. And I would request Dr. Anuradha to take us into the technical aspects of these testing and what we need to know at a molecular level.
Thank you, Dr. Jay, for the wonderful presentation. Dr. Jay has an important surgery to get to, so I will leave it to him as far as when he needs to go. We can take questions. I leave it to you. Please let me know how much time you have.
No, they've called me in the OT because some other people have come inside again. So I would request to relieve me, and you can take over the session and answer the questions to everyone. Yeah.
Thank you. Okay.
Thank you so much, ma'am. Thank you, Metropolis, once again.
All right. I am happy to answer a couple of questions as they come our way. But till we get a couple of questions, I will walk through some of the PGT, which Dr. Jay Mehta explained. There's the PGTA and the PGTM, where the PGTM is looking for specific mutations or defects in our genes. We have when a couple wants to get pregnant and they have a prior child with a defective mutation which causes disease, so we can look at the embryo and try to figure out what if the defect is actually present in the embryo. And if it is present in the embryo, those will not get implanted. It's going to be the ones which don't have the defect that get implanted. A lot of the times the questions come is, what kind of defects are you looking for? So when we look for defects, the defects can be pathogenic, they can be benign, and they can be variants of unclear significance. What does that mean? So pathogenic is when the defect is actually causing the disease. Benign means it's not actually causing the disease. And variants of unclear significance is where it's may or may not cause the disease. We are not sure. And that's when we look at the patient history and look to see what's going on. A lot of times when we test the couple coming in for these mutation testing and we are testing them, we may get 3 or 4 findings. And we may get one gene which is pathogenic, one gene which is benign, and one gene which is a variant of unclear significance. So we need to really look at the history of the patient, the history of the family, and put it together with what findings we are getting. So that is PGTM in a nutshell. PGTA, they are looking at the aneuploidies, as Dr. Jay Mehta explained, which is 13, 18, 21, X and Y for the most part. They also look for others. And as Dr. Jay Mehta explained, you are only going to put in aneuploidies for, you're not going to put in any aneuploidies. You're just going to put in either the euploids, or if we don't get enough embryos, the mosaics, which is God's gift. So that is PGTA in a nutshell. There's nature's way of resolving this with the mosaic, and sometimes even with the aneuploids. Sometimes the aneuploids, which may be defective, they resolve, but we don't want to take a chance. And literature has shown that these defective embryos do not usually produce good results. But if we don't have any embryos, worst comes to worst, depending on what's going on, can be implanted. There are certain techniques you use to get these embryos and to go through this testing. It's a specialized training which is required to get this biopsy, embryonic biopsy, to make sure we're not damaging the embryo and making sure the tissue we are getting is accurate and will actually give results. So that is PGTA, PGTM. Now there's PGS, which is pre-implantation genetic screening, which is sometimes done. The American College of Medical Genetics usually does not recommend this with screening for anything in particular, because you are going to get results which don't really make a lot of sense. So if there's a person with multiple miscarriages, if there's a person with prior history in the family of something, then yes, we could do the PGTA and the PGTM, but the PGS, just to look for problems, is not recommended. Now, then the IVF couple goes and gets the PGS testing, and after the pre-implantation genetic testing, and after that, they get pregnant. So once they get pregnant, there are other genetic tests we can do. The first one is NIPT, which is non-invasive testing, which is self-free. And what that looks for is chromosomal abnormalities in the mother. Now, that is a universal screen that is looked for. And you look for chromosomal abnormalities in the mother for the fetus. So the most important, the most sensitive is chromosome 13, 18, 21, and the sex chromosomes. So those will be picked up at a 99.9% sensitivity rate. Usually, we will divide the NIPT results into, has a high risk or a moderate risk or a low risk for these chromosomal abnormalities, that does have to be put in conjunction with the ultrasound findings and the quad screen to see if you need to go through an amniocentesis or chorion villus biopsy. So when you go through the chorion villus biopsy is done at a little, I guess, a little earlier. And then amniocentesis is done around 14 weeks of pregnancy or 15 weeks of pregnancy. And there's where you take out some fluid and you look for any chromosomal abnormality to confirm the NIPT result. So, for example, the NIPT has shown a chromosome 13 abnormality. So at 15, 16 weeks of pregnancy or earlier 10, 12 weeks at pregnancy with CVS, you take out some tissue, you look for chromosomal abnormalities. Now, there are multiple tests you can do. If you, based on the ultrasound result, based on everything you're given, you can straight away do a karyotype where you culture the cells and look for an abnormality. The problem with that, it takes a little long to culture the cells. And the results are in about 15 days. You can look for chromosome abnormalities which are there, but you can also look for any imbalances or any changes or anything in the parents. So when you look at the karyotype of the child, you can of course get the blood of the parents and to take a look at chromosome abnormalities in the parents, which is causing problems in the child. For example, sometimes there's a rearrangement of chromosomes, which is completely normal in the parents, and that's called a translocation. But when it comes into the child, you can have an imbalance, and that can cause a chromosomal abnormality in the child. Now, so the karyotype will look for those two things. The other test you can do is FISH, which is fluorescent in situ hybridization, where you have a probe that attaches just to that chromosome point to look for that chromosome abnormality. The problem with that is it's not going to look at all the chromosomes. It will only look for the chromosome you're suspecting. Like you may only be able to look for 13 or 18 or 21 or just those three. You cannot look at everything. The last test is a chromosome microarray, which you can do, which looks for even the smallest amount of chromosome imbalance where there's a loss or gain of DNA. So you basically have DNA probes across your chromosomes, across your DNA. And what those probes do is they attach to your genetic material and it shows whether there's a loss or gain of chromosomal material or loss or gain of DNA when you compare it to a control. What it will not catch is any balanced chromosome translocation. So if you do it in a parent, you're going to find it completely normal in the parent because there's no loss or gain of chromosomal material in the parent. There's just a balanced translocation. But what the good news is about that, you can catch even the smallest chromosomal imbalance. I will give an example. We have a heart disease in the fetus and the NIPT is normal or low risk, and then you still see the heart disease. So you will want to do an amniocentesis. You do the karyotype is normal, and then you do the FISH is normal for 13, 18, 21. Then you do an amniocentesis and you do the microarray, and the microarray shows a loss of material on chromosome 22. And that loss of material on chromosome 22 is associated with something called DiGeorge syndrome, which is associated with heart issues, is associated with developmental delay, is associated with hyperthyroidism and things like that, and low immunoglobulins. So these are things we can look for, and then you can counsel the parents as far as this is what we can expect. Of course, you're not going to see everything what we are talking about, but there are certain things we can see in the child, and that's what you look for. So those are some of the genetic tests we do during pregnancy. I am happy to take questions at this point.
one ovary is removed due to PCOD, can we still have chances for a normal baby?
Okay. All right. So should I start with that question?
Yeah, sure.
All right. One of the questions which has been asked is if one ovary is removed due to PCOS, is there still chance for a normal pregnancy? And the answer to that is yes. There are chances. Now, with PCOS, there are other issues which have come about. One of the things is having a healthy mother. So there's diet and exercise to make sure that you're as healthy as possible. But once you go through IVF and you have your embryos, yes, there is still a very good chance of having a normal pregnancy and a baby. With PCOS, you actually have a lot of eggs, and you can have a lot of embryos. So there's always a chance of hyperstimulation with PCOS, but as long as experienced IVF specialists will do it right and have enough embryos that you can have a chance of having a normal pregnancy and a normal baby. There's no genetic problem with that.
There's one more. Please
Mhm.
share insights on PCP and D regulations with respect to prenatal screening tests. Would you want to take that?
I am not familiar with the PCPND so far. I'm sorry, but I can address it. Okay. Another question that comes is, what is the PCPND regulations of prenatal screening tests? As far as the regulations go, PCPND, I'm not sure they've made too many regulations yet, but I am not completely certain. I am happy to get back to you on that, as we do know that you need to be certified with PCPND, but as far as screening tests, I don't believe they've actually addressed that. All right, if there are no more questions, thank you so much for attending MedConnect. It was a pleasure talking about this, and hopefully we will see you next time with another topic. Thank you again.